Good evening and welcome to our webinar to all the members of National API. And we have very exciting speakers today to talk about COVID-19 updates, including most hot topic, vaccine. It's my honor to introduce today's moderator, Dr. Rupesh Raina, is an adult pediatric kidney disease and hypertension nephrologist at Akron Children's Hospital and Akron General Medical Center at Cleveland Clinic Foundation. He is Associate Professor of NeoMed Medical University and Case Western Reserve University, Cleveland, Ohio. He is a council member of the Faculty of Internal Medicine, Council at NeoMed. Dr. Raina is the Pediatric Education Committee member for the International Society of Nephrology. He is a fellow of National Kidney Foundation and American Society of Nephrology. Additionally, Dr. Raina serves the National Kidney Foundation Advisory Board, Ohio. Dr. Raina practice include care of patients with disorder of the kidney, including chronic kidney disease, nephrotic syndrome, and glomerulonephritis, and tubular disorders, cystic kidney disease, kidney malformation, and neonatal acute kidney injury, kidney stones, and hypertension. He also provides medical supervision of dialysis treatment, plasma exchange, and kidney transplantation adults and children. Dr. Raina clinical research interests include transition of adolescent with chronic renal disease to adulthood care, renal replacement therapy in acute and renal failure, bone marrow transplant, and inherited metabolic diseases. Basic science research include, but not limited to, identify non-invasive biomarkers, predict adult disease and pediatric kidney disease and disease progression. Without further ado, I welcome Dr. Rupesh Raina. Good evening.
Thank you. Thanks a lot. Good evening, everybody. I think this is a perfect timing for to have a global COVID-19 epidemiology lab work and the vaccine update, because we just are in a process of getting the vaccine in this pandemic, which is globally and has really paralyzed the system and put the people more kind of facing the global epidemic with limited armamentarium. So today it's a nice forum to have the key leaders who were involved in looking at the epidemiology and also workup for the vaccine update. With that, I'll start the program. And the first speaker that I want to introduce is Dr. Kashmira Date. She's a MD and she's International Task Force Epidemiology team member. She's a team lead for 2019 novel coronavirus response. And she's also involved in the Center for Disease Control and Prevention. It's my honor to introduce and welcome Dr. Kashmira Date.
Thank you very much for this very kind introduction. Can I go ahead and share my screen?
Sure.
Okay, can you all see my full screen?
Yes.
Okay, great. So again, thank you very much for inviting us to present here today on the epidemiology and laboratory updates that me and my colleague, Dr. Todd Davis from CDC will provide. So I just wanted to give a couple of quick updates in terms of, we are going to be presenting primarily, or almost everything from the international side, in terms of the epidemiology and laboratory aspects. So if there's anything domestic, we can take that back to our colleagues at CDC. So I just wanted to mention very quickly that, as you all know, that the situation is rapidly evolving. A lot of the data that I will be presenting, just wanted to provide some caution in terms of the numbers. The data cleaning are always ongoing, so all numbers should be interpreted with caution. Just quickly wanted to mention that as of December 10th, over 68 million cases have been reported worldwide. The data presented here come from case report forms representing only about 39% of all reported cases. So in terms of the representativeness, we also see a lack of completeness in the variables, the individual level variables that are reported. So, I just wanted to provide that caveat before we go into the different data aspects. So this is the slide. Again, I think you've all kind of seen the different numbers, the global epidemiology, the situation report. Basically, I mean, again, this is a little bit older data. So it's, as of 9th of December, we have over 67 million cases worldwide. When you looked at the last 24 hours, over 500,000 cases reported, 500,000 cases reported worldwide. When you look at the deaths, over 1.5 million deaths and, around 10,000 in the last 24 hours. So this is the epi curve globally that's kind of divided by the different WHO regions. That shows the region of the Americas, the Southeast Asia region, the Europe region, Eastern Mediterranean, Africa, Western Pacific. So these are the different WHO regions, and that's how we end up looking at the data. So this is the epi curve that shows, the case numbers per region, and then the line here represents the deaths. As you can see, cases have been increasing over the past several months. This table here on the right side is how we look at the data in terms of the average daily incidence and the cases that were reported last week, and how that and this week, and how that kind of represents some of the number, the percent change in weekly cases. So that helps us monitor some of the, sort of the weekly progression of the epidemic worldwide. So when you look at the different numbers for the different WHO region, compared this week, or, I mean, now I'm talking about the past week because this is data as of 9th of December. The past week compared with the previous week, we see that the region of the Americas and Africa did show a significant rise in the number of weekly cases. When you look at the CRO region, with the European region and the Eastern Mediterranean, there was a slight decrease in the number of cases compared with what was seen in the previous week, but we still see a significant number of cases within this region, and especially in the European region. So this gives us an idea of how, the epidemic is progressing across the different regions. This is another way in which we look at the data. So this is again looking at the 2-week incidence. So looking at the number of cases by the population numbers, and then the case counts by country. So the colors here represents the 2-week incidence per 100,000 population. The darker the color, the higher the incidence in those countries. And as you can see, what we see here in the US and in certain countries in Europe, that's where, we are seeing the highest incidence and the highest 2-week cumulative number of cases over a 2-week period. This is another way in which we kind of look at how the burden is actually growing, or whether it's kind of remained in a steady state. So what we call as a case trajectory map. So this kind of helps us look at how the different countries, how the epidemic is again progressing in those different countries in the past 2 weeks. So the darker, again, the color basically shows that these are the countries that have a high burden, and the epidemic is also growing in those countries. Now, again, I'll talk about a little bit later in terms of how that compares with the testing data and some of the other numbers that we are looking at. And so, as you can see here, the Southeast Asia, the Asia region, and in Africa, it's actually showing not a high burden, and it's not growing. But again, those numbers have to be interpreted in the overall context of other data that are available. So, this is another way again of how we are visualizing the epidemic curve by region, and it has in the different regions. Now, note that the scale for each of the regions is actually scaled for the numbers that are actually, so it's not a uniform scale, but it just shows how the epidemic is actually progressing within the region. So if you look at the, the X and the Y axis, it's a little bit different per each of the regions here. But again, you'll see that if you look at Europe, you're seeing the first wave and then a significant second wave. Whereas when you look at some of the other regions, it's a little bit different. In Africa, I mean, we've seen that first wave now, and cases are decreasing. Looking at Southeast Asia, there was a big first wave, and it's kind of going in that direction. We are not seeing that wave pattern in that region. So again, looking at some of the data, and again, I'll talk a little bit about this in the context of the other regions. But this is how we look at what we call as the test positivity data. So when we look at the number of, how the testing is being performed in these different regions, we already know that in Africa, for example, there is limited testing that's happening. So because limited testing makes it likely that many cases will be missed, the positivity rate can help us understand how the virus is spreading. So in countries with a high positivity rate, the number of confirmed cases is likely to represent only a small fraction of the true number of infections. So that's something that we just need to remember as we are looking at all of these different data sources. So very quickly, just understanding the age and sex overview of what we are seeing overall globally. So as you can see here, the different age groups, as you can see now, I mean, this is again the cumulative numbers that were reported to WHO. A bulk of the cases are actually occurring in that sort of mid, age group range. So anywhere between the adult age group here, the 20s, and the younger adult age group. But when you actually look at the deaths, that is much higher in the older age groups. And again, this kind of shows the sex distribution among the cases and deaths. And these are the confirmed cases and the confirmed deaths that are attributed to COVID. Again, this is another way in which we work with WHO to sort of track the data that shows that how there is a change in the age distribution of cases over time. And then again, the change in the distribution, the age distribution of deaths over time. As you can see here, a bulk of the cases are within that younger adult age group. But when you look at the deaths, it's in the older age groups, and this is the percent of all cases and all deaths. And you can see here how things have been changing over the course of the epidemic per the week of the reporting. So this is something that I thought would be of interest to you all, as we already know, the cases among known healthcare workers. So this is how WHO is kind of tracking some of that information in terms of the proportion of healthcare workers, so this, I can't point out right here, but this is the age distribution of the cases among healthcare workers. So again, a higher actually proportion of cases with known healthcare worker status among females compared with what we've seen in men. And then among the deaths, we actually see those higher, for at least the where we know the age and the case sex distribution among males. So I think this is a pretty grim statistic that we need to be very careful about. So this again, I just want to show the map of laboratory testing that is happening overall. So over the past 30 days, as you can see here, so the darker colors is basically where there is more testing happening compared with countries where we know that there is less testing that is happening. And my colleague, Dr. Todd Davis, will talk a little bit more on the testing front here. So again, as we see here, the region of the Americas, European region, and some countries in Asia are doing more number of testing. And then, in Africa, we do see that there are quite a number of testing gaps over the past 30 days. And that's kind of remained constant over the course of the epidemic. So again, just reminding everybody that this is when we actually look at that the test positivity rate, because if you look at Africa here, although we know that there is limited testing, there is a higher test positivity rate. So again, something to make sure that we account for. So this is another way, and again, my colleague will talk a little bit more about the serology testing that's happening globally. But this actually shows the cumulative incidence and the percent seroprevalence by country. This is again data as of September 30th that we are aware of. So a number of countries are actually conducting seroprevalence studies to understand better the infection rates in the country. So we know that, again, the number of cases that are confirmed only represents a certain proportion of cases. So this is what now shows how the serology testing compares among countries. Now, again, this is also, most of these are early serology test seroprevalence studies that were done primarily in higher income countries. I mean, of course, we have a few countries in Africa and in Asia, and this is not really completely representative, but gives us a good idea. Say, for example, in some of the countries, we did find that there was a higher seroprevalence when we looked at some of the serology data that was coming out. So just very quickly, I want to touch on the second wave in Europe. And so when we've analyzed some of the data looking at Europe, basically what happened was that there was that significant first wave. There were quite a few mitigation measures that were implemented and the cases dropped. But then there was, again, the summer in Europe, the mobility increased, and we saw that, again, the cases now sharply increased. And similarly, the deaths kind of trended a little bit later, but have also picked up again. Now, we are seeing that it is declining over the past few weeks, and as they have implemented some more mitigation measures and more lockdowns, we are seeing some of those changes again happening. But that does account for a significant number. So the second highest number of new cases and deaths that are reported globally, and the highest number in the last week have been in these countries. So very quickly about Southeast Asia region, which I know that a lot of you might be interested in seeing what's happening in these countries. So in Southeast Asia, the cumulative numbers are high, but we've seen that there have been an overall decline in the weekly cases, and there has been a slight increase in the deaths. But again, sometimes it's also a reporting artifact that we need to account for on a week-by-week basis. India does account for about 76% of weekly cases and about 70% of weekly deaths that are occurring in the Southeast Asia region. India, Indonesia, and Bangladesh have the highest number of weekly cases in the Southeast Asia region. But overall, over the past couple of months, there has been a decline in the number of cases. So very quickly here, I just wanted to mention that some of these data, as you know, are already available within on the Ministry of Health and Family Welfare data, as well as the Indian Council of Medical Research. So, again, this shows
that this is kind of like, how the epidemic is going on in India. What are the new cases that are being reported? What is the 7-day change in those case numbers, the new deaths again, and what is the 7-day change in those numbers, and what the case fatality rate looks like. It might be interesting to also look at some of the public health measures and social measures that have been implemented during that past week. So they do update these on a regular basis. So there is a partial movement restriction that we know is occurring across different parts of India. Public transport has resumed, but again, there are quite a few subnational variations on how these kind of are implemented across states. Similarly, for what's happening across schools and then public gatherings, that also varies. Now, the good thing is that there is a mandatory face cover mitigation policy that has been implemented across most states in India. So this is another way in which I just wanted to very quickly mention how we look at the analyses of what we call as the mortality, mitigation, and mobility data. And I'm just showing, primarily for India here, but also for Nepal and Bangladesh, just to say how it kind of compares within the region and some of the neighboring states or neighboring countries. So if you see the blue line on this graph represents what is called as the Oxford Stringency Index. So that's available on the University of Oxford website. It tracks there are 9 different mitigation policies that it basically tracks. So it tracks the stringency of these policies. So the higher the number here, that means that is a higher policy stringency that's happening across these countries. So as you can see here, everything pretty much starts from 0. So basically there was no stringency when the epidemic started, but as the epidemic progressed, there was a higher stringency in the mitigation policies. And suddenly, as you can see here, around that March timeframe, there was pretty much a lockdown that happened in most of these countries. So suddenly that bar is a little bit higher for the blue line that we see here. So similarly, the movement, which is in the orange line, shows that the movement was pretty much, so the higher than the bar here basically shows that the movement was freely open, but then suddenly with all of those mitigation policies in place, the movement completely dropped. And then when you look at the red line, it shows, how the mortality kind of played out when these mitigation policies were implemented and the stringency of these were, and the movement really reduced. Now, again, some of those may be how deaths are reported, and these are all the reported deaths. There's another way in which we look at the data that I'm not presenting in the interest of time, but is something called as excess deaths. So when we look at, so these are now only the COVID reported deaths, but when we look at something called as excess deaths, what basically we see is that there are these additional deaths that are reported compared with what we saw around the same time frame last year. So that may indicate that these may be COVID-related deaths, or these may be other deaths that may be what we call as this collateral damage, that people may die of other conditions and they're not able to access healthcare services, maybe dying of heart attacks, maybe dying of other causes, but are not able to get healthcare services because of the whole COVID-related situation. So I'm not presenting that in the interest of time, but that's again something that we help track how the epidemic is really impacting populations at every level globally. So that's the end of my presentation. So maybe I'll just pause here and see if, and my colleague will present later. So over to you, Dr. Rupesh.
Thank you. Thanks. Excellent presentation and excellent epidemiological trend that I have seen. So I think what I will prefer is at the end, we'll have questions for all 3 of you together, because I didn't see any question coming up in the chat. And I'll have my own, which I'll try to do it all together when all the 3 presentations are done, if that's okay with you. So we'll move on to the next talk. And actually, the next speaker, I've heard his name when I was doing a fellowship in Cleveland Clinic in nephrology. That's Dr. Todd Davis. He's an international task force laboratory team lead, and he's been working extensively in 2019 novel coronavirus response, and he's working in Center for Disease Control and Prevention. If you look into his CVs and publication, they are wide variety, and he has published a lot in H1N1 when I was doing my fellowship in Cleveland Clinic, and Dr. Davis is the lead for the zoonotic virus team within the virology surveillance and diagnostic branch. He has an extensive work on H1N1, which further lead to the more detailed workup for the COVID-19. So I will give it to Dr. Davis, and he has extensive publication, multiple publications on H1N1, a lot of work on virology. And with this, I will give the podium to Dr. Davis.
Thank you very much for the kind words. And thanks very much for the invitation to speak to everyone. Kashmira is going to help me to forward the slides. So Kashmira, we'll start with the next slide, please. And so tonight I wanted to talk about some of the updates to recommendations for SARS-CoV-2 testing strategies. And again, with the focus on the international side of things, as my group within the CDC is focused on providing recommendations and strategies for testing in the international space, but we'll also include some of the CDC guidance that's focused on our domestic response as well. Next slide. So just to begin, I'll focus first on nucleic acid amplification testing strategies and some of the updates to those strategies, and then talk a little bit about antigen rapid diagnostic tests, and finally serology tests. Next slide. So beginning with the nucleic acid amplification test, or the so-called NAAT test, as you may hear more frequently used among scientific jargon to describe these tests. These are essentially all molecular-based assays, but most of the tests that have been FDA regulatory approved or WHO emergency use listed fall into this category of nucleic acid amplification test. And as of the 9th of December, there were more than 100 emergency use authorizations by the FDA and 19 emergency use listings by the World Health Organization. There have also been a number of multiplex RT-PCR assays that are now currently available on the commercial market, and also through CDC's own work, as they have developed a SARS-CoV-2 and influenza multiplex assay that is now being rolled out to many of our national influenza centers as part of the GISRIS, or the Global Influenza Surveillance and Response Network, as part of our work with the World Health Organization. There's also a number of other commercially available multiplex assays that not only target SARS-CoV-2 and influenza, but a number of other respiratory pathogens. And one good example is the BioFire panel. There has recently been an expansion of molecular tests that are related to more novel technologies, such as loop-mediated isothermal amplification. One of the more recent advances that I won't talk about in any detail is an at-home self-test that not only relies on self-collection of the sample, but actually running the assay in your home. And that's based on a loop-mediated isothermal amplification step that can be performed in about 15 to 20 minutes in your own home. And of course, there's also some sequencing that's ongoing within a lot of different laboratories, and those clinical laboratories that have sequencing capacity are also able to use some regulatory authorized tests for sequencing. Next slide. Thanks, Kashmir. So, of course, one of the things that's always complex about interpretation of data is the cycle threshold values that result from the majority of the nucleic acid amplification test. And so in symptomatic individuals, we expect viral RNA to be detectable as early as day 1, and then peaking within the first week of symptom onset. And so typically a CT value of less than 40 is considered to be clinically reportable as a positive case. Now, the viral RNA starts to decline by week 3 and then subsequently becomes undetectable. But we know that there have been a lot of cases reported that are so-called persistent positive cases, where the detection of viral RNA can last for several months. And I think there's some very interesting research going on about the possibility of those viral RNA elements persisting in lung respiratory samples. So we encourage laboratories to initiate standard operating procedures within their clinical settings or their laboratory settings, so that the CT value interpretation is really guided by standard operating procedures and centralized decision making, so that there is less room for interpretation of those CT values, and really trying to make those results more black and white in their interpretation. Now, as I mentioned, the CT values from severely ill and hospitalized patients, typically are lower than those CT values of mild cases. And so, of course, there's a lot of work to try and understand the difference between those symptomatic individuals versus asymptomatic individuals, and also the CT values that might result from those more severe cases. And finally, that leads to some trouble that laboratories might run into related to weak RT-PCR CT values, where the CT values can be very high, above 35, and those can be resulting from nucleic acid mismatches in the nucleotide sequences of the SARS-CoV-2 virus that have been reported from time to time, as well as the timing of the symptom onset to when those specimens are collected. Next slide. And this has led to a lot of work also looking at this possibility of reinfection among individuals. And so the CDC has developed guidance, as well as the World Health Organization and the Pan American Health Organization, around the so-called reinfection capacity for individuals to have more than one infection with SARS-CoV-2 virus. And so there are now investigative criteria to define what we mean by reinfection. And so there's two different scenarios. One is for persons that either are asymptomatic or symptomatic, but where there is detection of SARS-CoV-2 RNA separated by samples that are collected at least 90 days apart from each other. And so that's a clear indication of that secondary infection if you see a positive PCR assay or nucleic acid amplification test in samples collected greater than 90 days apart. But there's also the possibility of persons to have reinfection in less than 90 days. And so the criteria defined by CDC specifies that if you're looking at samples collected between 45 to 89 days from the first sample collection to the second sample collection, that this has to be done with only symptomatic individuals. And the idea is that by focusing only on those symptomatic individuals, you would reduce the burden to the laboratories that are doing that testing. And given the number of persistent positive PCR cases that we've detected over the past several months, this would hopefully reduce some of the burden on the laboratories that are performing the testing. Next slide. So some of the additional criteria to establish evidence for reinfection is based on sequence comparison of the first sample compared to the second sample. And so the best evidence would, of course, be looking at very different SARS-CoV-2 viruses based on the sequence identity of those viruses, and even different clades. And those can be easily defined now using sequencing databases like the NextStrain and the GISAID databases to compare sequences from one sample to the next. The other evidence that's generally pretty conclusive is when you can culture virus from both the primary and the secondary infection, especially when they're separated over that 90-day period. More moderate evidence is based on fewer sequencing changes, but still observable sequencing changes. And so having a secondary sample with greater than 2 nucleotide differences per month on the consensus sequence is also decent evidence that there's been a secondary or reinfection. And then more poor evidence would be those sequences that result in fewer than 2 nucleotide differences in the samples that are collected in that primary versus secondary infection, and where you might have virus that is not culturable, or using some more sophisticated assays such as subgenomic RNA assays that are able to differentiate between actively replicating virus versus non-replicating virus, and a comparison between those subgenomic RNA components. Next slide. So of course, there's been a lot of different nucleic acid amplification strategies developed and different testing that's based on the sample types. And so of course, I think most of you have probably heard about saliva being used as a sample type. This is a well sought after assay because it's a non-invasive assay. So it's easier to collect those samples, oftentimes easier to pool samples based on saliva. And nasal swabs and nasal mid-turbinate swabs, especially in asymptomatic people, have now been shown to be extremely valuable, and the sensitivity has been shown to work quite well compared to those nasopharyngeal swabs that are more difficult to collect. The FDA has also issued quite a few assays now that have pooling as part of the algorithm for using their emergency use authorized assays. And so pooling is also becoming a more important strategy and is used internationally quite often. And then finally, the FDA does offer a lot of alternative nucleic acid extraction strategies. And so given the limitations and the resource limitations specifically around nucleic acid extraction kits, there's been a lot of guidance, and especially in the international stage, a lot of efforts into using bridging studies to test and verify, validate assays using alternative lysis buffers or extraction methods. Although this can be labor and resource intensive, it can also offer some real strategies, important strategies to be able to test as many samples as you want. And then finally, heat treatment is becoming a more commonly used methodology. It's not an RNA extraction process, but does lyse the cell and release the genetic material. And heat treatment is becoming a more commonly used strategy for nucleic acid amplification testing. Next slide. Just briefly, I'll mention again saliva as a sample type. There's been a lot of very interesting literature describing saliva and its utility, and some of the things that I've already mentioned. And again, one of the things that I think people really find useful is that it's very easy to pool samples in a single tube using the saliva strategy. And of course, the ease of collection and some of the cost-effective methods, such as not having to swab and maintain sterile swabs, is something that clinicians are finding to be very useful. Next slide. So now I'll talk a little bit about the antigen-based rapid diagnostic test and some of the more recent guidelines that CDC has established. Next slide. So the antigen-based rapid diagnostic tests, of course, have a very important role in their capacity to test a large number of samples over a very short period of time. So for most of these assays, results are obtained within 10 to 30 minutes. While you typically do have to get a very good swab, and nasopharyngeal swabs are still the gold standard for the antigen-based rapid diagnostic test, the sensitivity and specificity can change considerably depending on the sample collection methods. But again, these are useful because of the point of care settings that they can be used in. They're generally easy to use, very low complexity. And there's been quite a few assays that have recently received FDA emergency use authorization and WHO emergency use listing. And so there's been a real drive in expanding use of rapid diagnostic antigen-based test, which I'll talk a little bit in a minute just about the situation specifically in India. And then I'll talk a little bit about some of the caveats to using these antigen-based tests. Next slide. So this is a table that just highlights, at least domestically in the United States, the 8 FDA, EUA regulatory approved antigen-based rapid diagnostic tests. And so as you can see, based on the manufacturer's results, you generally see high sensitivity and even higher specificity in the majority of these antigen RDTs that are commercially available. Next slide. And the same is generally true for the WHO emergency use listing. And so there have been 2 antigen-based rapid diagnostic tests that the WHO has listed for approval, specifically in the international settings. And those are shown there. And again, with generally high sensitivity and even higher specificity although some lower sensitivities that have been detected in different case investigations in certain countries. Next slide. So recently, and this is new information within the past week and a half, CDC has issued updated guidance on the utility of antigen-based rapid diagnostic tests under different scenarios. And this is really focused on the scenarios that might lead to both a high pretest probability, a moderate pretest probability, and a lower pretest probability. And so you can imagine for those high pretest probabilities, where you have symptomatic individuals, a positive antigen test could be generally considered as indicative of a confirmed infection with SARS-CoV-2 virus, whereas a negative antigen test may require confirmation by a nucleic acid test. For that moderate group where you have moderate pretest probability, this is a scenario where you have asymptomatic or a close contact with the COVID-19 confirmed case. And in this situation, the CDC's recommendation is that for the positive antigen test in an asymptomatic individual, that you would want to do confirmatory nucleic acid amplification testing to confirm that positive result. But for the negative antigen rapid diagnostic test, that would be considered confirmatory for evidence of a negative result or no current infection. Of course, with the caveat that there may be some clinical discretion required by the clinician to consider when that confirmatory testing is necessary. And then finally, for those low pretest probabilities, and this is asymptomatic individuals that have no known exposure, or at least no known exposure within the last 14 days, that those positive antigen rapid diagnostic tests would require confirmation by a nucleic acid amplification test. And where that negative antigen rapid diagnostic test would be confirmatory for not being infected with SARS-CoV-2. So you'll notice in this guidance that there are quite a few footnotes, and I encourage everyone to look at these resources that are now on the CDC's website that provide quite a few caveats to using these tests. I won't go through all of those, but a lot of them really do have to do with the clinician's discretion and the case history of the individual and the pretest probabilities. Next slide. So of course, because of some of the lower sensitivities that we're now hearing about as more and more countries and in the United States are using the antigen test and comparing them to nucleic acid amplification tests, there's been a really desperate need for verification and validation of these assays. And so there's quite a few groups, some of which are sponsored by the Bill and Melinda Gates Foundation, as well as other funding agencies to help promote the evaluation of the clinical performance of these antigen-based RDTs. One such group that we discuss data frequently is the Foundation for Innovative New Diagnostics, where they're constantly testing new antigen-based RDTs that have become commercially available. And now globally, we know that there's at least 90 different antigen-based rapid diagnostic tests that are becoming commercially available. So given the number of commercially available tests, generally the high sensitivity and high specificity, there's been a lot of field evaluations ongoing to understand how well these assays actually perform in the field. And India, interestingly, has reported the greatest scale up of SARS-CoV-2 antigen testing of any country to date. And so back in June, as we worked with our CDC country office in India, there were only about 4,000 antigen tests that have been completed. But when we look at the information collected in September and October, we see more than 1 million antigen rapid diagnostic tests that have been used in India. And India also had rapidly diversified the number of different tests that could be regulatory approved. And as of October, there were at least 5 SARS-CoV-2 rapid antigen tests available for use in India. And as I mentioned, what was seen in India and has been seen in other field evaluations, unfortunately, is a decline in the sensitivity of these assays in their field performance versus what the manufacturers have reported. And so that's something that we address quite frequently in many countries that are beginning to expand their use of antigen-based rapid diagnostic tests. And I suspect that we'll hear a lot more about the utility of those assays over the coming weeks and months. Next slide. So finally, I'll close with a brief discussion about serology testing. Next slide. So serology testing, or antibody assays that are used, of course, are looking for detection of immunoglobulins in individuals that may or may not have been exposed to SARS-CoV-2 virus. And there's a number of different antibody tests available on the market. But this figure that's shown here is one that may be familiar to many of you, looking at when both IgG and IgM antibodies begin to be elicited within the viral response. And so you can see that about the beginning of week 2 post-infection, you start to see a rise in both IgM and IgG, with IgG persisting for quite a few weeks beyond IgM. And most of the antibody assays are focused on both combined IgG and IgM, but there are some assays that target either of these, as well as some that also incorporate IgA as a metric to assess that early immune response. Next slide. So again, as of the 9th of December, the FDA had approved 20 different serology or antibody rapid diagnostic tests and 38 ELISA tests. And then FIND, the Foundation for Innovative New Diagnostics, just as they have done for the antigen rapid test, they've also evaluated the performance characteristics of many of these serology tests, including 26 different serology rapid tests and 8 ELISA tests. Next slide. So another thing that the International Task Force has been working on has been helping international laboratories and our CDC country offices globally to initiate seroprevalence studies. So there's quite a lot of funding available to CDC country offices to support their lab networks in designing seroprevalence studies to capture baseline information in the early stages of the pandemic, and then changing epidemiology through the months that have continued. And then finally, also to be able to capture that baseline serology data so that once vaccine is rolled out into communities, that they would have some information to look at vaccine efficacy compared to what the baseline numbers look like. And so as we have worked with many different countries to help design and implement seroprevalence studies, one of the things that we've found also is a decline in the general sensitivity and specificity of the serology assays that are being used. And also quite a bit more cross-reactivity with other antibodies from other pathogens than we might have expected. So a lot of the early results were from US populations or blood bank donations, where I think the sera was very clean, but as you begin to look in certain regions, for example, in sub-Saharan Africa, where there's a high incidence of malaria, we've seen more and more evidence of cross-reactivity with Plasmodium antibodies. And so that's something else that we're really careful in looking into to understand how well these serology assays work. And so one of the things that we encourage is doing some algorithms that involve using more than one test. And as you can see from this data here, that as 2 tests are used, you get a positive predictive value that is much higher than when you just use a single test alone. So I think we'll start to see a lot more really interesting data coming out of some of those regions where that cross-reactivity is becoming a problem, and where either serial testing or orthogonal testing is increasing the positive predictive values. Next slide. And then just to close with the serology. So again, there's still a lot of information, I think, that's unknown about how quickly antibodies are peaking and the persistence of those antibodies in individuals, whether or not they provide correlates of immunity is another area that we're really focused from a research perspective. And of course, once vaccines are rolled out, I think that'll be really critical in our understanding of how well vaccination is effective in inducing both IgM and IgG and the persistence of those antibodies over time. And then finally, in our work with a lot of our international colleagues, we're beginning to look at alternative sample types, whereas most of these assays rely on plasma or serum from venous blood draws. We're also starting to explore using dried blood spots, for example, as a sample type for both the rapid serology tests as well as the ELISA-based tests. Next slide. And finally, and Kashmira, feel free to jump in. We've included some resources and helpful links that focus on some of the things that both of us have covered. Kashmira, if you want to add anything, please do. But these links will be useful, I think, to capture many of the things that we've discussed tonight. Over.
Thank you, Dr. Davis. I think after your talk and after Dr. Date's talk, looks like we have a lot of questions accumulating. So what we can do is at the end, we will have 3 of you as a panel and answer the question, because some of them are directed towards you and some of them are directed to Dr. Date. So I'll work on that. And then let's complete our talk, and then we'll have like a panel to just answer these questions, and you can chime in with each and specific question that's pertinent to. Now, the third speaker, it's my pleasure to introduce Dr. Chen. Dr. Chen is an adult infectious disease physician scientist with a specific interest in clinical vaccines. He's a professor of medicine at the University of Maryland School of Medicine. He's the chief of adult clinical study section at the Center for Vaccine Development and Global Health, and a director of the University of Maryland Travel Medicine Practice. His research career has been focused on developing vaccines against the pathogen of global health importance. And Dr. Chen is actually currently serving as a member of Governor Larry Hogan's COVID-19 task force, co-leading the Maryland Department of Health statewide serology surveillance program of COVID-19. And he's also a co-principal investigator of CDC-funded COVID-19 syndrome surveillance program, which is being implemented through the University of Maryland Medical System. Welcome, Dr. Chen.
Thank you for having me, and thank you for the organizers for putting this together. Can you hear me? Is the volume good?
Yes.
And can you see the slides? All right, very good. So let's see here. Okay. All right, so I'm going to be talking about vaccines predominantly. And one thing I like to always show in the beginning is to help people to understand the spectrum for what is the normal timeline for a vaccine to be developed, from the inception of the idea all the way through the clinical trials, the licensure, policy implications, delivery, and then measuring the impact as well, because that's the whole spectrum that we are trying to cover. Normally, it takes 10 years or more. And in this instance, we're seeing that the first vaccine was developed within less than 12 months. And we closely on the heels of that, we expect that the Moderna vaccine will potentially be EUA approved, and the FDA VRBPAC will be meeting on that tomorrow. So, so this is just to really illustrate to you the idea that normally there has to be the recognition of a public health need and a market need for a vaccine to be developed and to go along this. And along the way, there's political will. Well, in the case of COVID-19, of course, we have been able to shorten this timeline so significantly such that we're able to arrive here now with a vaccine within less than 12 months, as I said. And a lot of it is because we've been able to remove the market aspect of it, which means that we've made significant investments without having to make business decisions for the R&D of these vaccines. And we also have the political will globally, of course, in the setting of this pandemic. So I think this is another slide that I'd like to spend a lot of time on, which is to talk just broadly about the different vaccine platforms that are being used to develop vaccines. So up in the right upper right corner is, of course, the SARS virus, and all of the vaccine development is really focused on eliciting immunity against the spike protein as really the predominant antigen of interest for all of these vaccines. And so how are these vaccines being developed and expressing the spike protein in these different formats? Well, the traditional approach for, say, influenza vaccine, which has been in existence for decades, is actually the chicken and egg approach, which means that every year, even up until now, the majority of our influenza vaccines are based on embryonated chicken eggs, where basically they take these individual chicken eggs and under a conveyor belt, under large manufacture conditions, they basically take the seed virus and inject it into the egg and let it incubate for a few days. We have replication of the virus to large amounts. Then it goes further on into the processing facility, and they're cracked open, centrifuged, purified out, and you have the viral components that are then deactivated, broken down into subunits, and eventually, again, purified and vialed. And that's how we make vaccine. But it's a very laborious process, and of course, it takes many millions of chicken eggs for us. So that's the traditional approach. And of course, that's a very slow approach where you have to have a well-established manufacture process to be able to make that vaccine from year to year for influenza vaccine. So there are newer approaches that I'm showing you here. So live attenuated viruses, that's a little bit newer, but we've been using them for many decades as well. That's, for example, yellow fever vaccine or measles vaccine. There's recombinant protein approaches where you basically take a bacterium and you make it express the protein of interest. And this is, for example, hepatitis B vaccine. There are cell culture-based ways of replicating virus so that you don't have to use the embryonated chicken egg. And then you can also add adjuvants to vaccines and make them much more potent as well. So an example is shingles vaccine, where we have a very efficacious vaccine for older adults, and basically it has a very potent immunostimulant, which makes it highly efficacious. Then that brings us to the future approaches, and I call them future approaches because before the pandemic, none of these vaccine platforms for basically expressing your antigen of interest were FDA approved licensed products. So we are now looking at the Pfizer vaccine, and now on the heels of that, the Moderna vaccine, both based on mRNA. There are also DNA vaccines. So Inovio is developing a DNA-based vaccine for, again, the expression of that spike protein. There are viral-like particles and virosomes that are also in development as well. That could be these newer or future approaches for vaccines. And then there's viral vectored vaccines for which the Janssen and the AstraZeneca are represented. So the chimpanzee adenovirus from AstraZeneca is a viral vector. They basically take the chimpanzee adenovirus and use that to express the spike protein. The Janssen also is an adenovirus-based, human adenovirus-based vaccine. So again, these are the different vaccine platforms. So that kind of gets you oriented to all the different vaccines that are under development right now. Here are the leading vaccines that are being developed, at least in the US. I did not list all of the vaccines, say like the Russian vaccine or some of the vaccines that are being developed by the Chinese. But Pfizer is an mRNA-based vaccine, as I said. We have the Moderna vaccine, also mRNA-based. AstraZeneca, Johnson & Johnson, the Janssen vaccine, both viral vectored vaccines. Novavax is a nanoparticle that's combined with an adjuvant. This nanoparticle basically is the spike protein, but it's also mixed with some saponins, cholesterols, and some other lipids and other things that are, in fact, proprietary. But we do know that that's how they characterize their vaccine as well. So those are the leading vaccines. We more recently heard some news about the Sanofi Pasteur product, and I think I addressed that in another slide. And Inovio as well is another vaccine, again, that I said is using the DNA-based approach. But in the end, you can see that there are almost 200 different COVID vaccines under different stages of development. Some of them are still in preclinical development, and then a few of them are in phase 1, 2, and then of course the ones in phase 3 are the ones I've listed already here. Okay, so let me just mention just briefly, just to orient you again, you may be very familiar with this, but this is just to make sure that I orient everyone for context purposes, the licensure pathway. So once we embark on a viable vaccine candidate that we'd like to have undergo human testing, it initially undergoes a phase 1 study. And those phase 1 studies are typically where the sample size is relatively small, where it might be 100 or maybe 200. And the purpose of the phase 1 is, because these are usually first in human studies, is the primary outcome is really looking at safety. So that's whether or not there are reactions or other adverse effects that might be associated with vaccination. Then we proceed to phase 2 studies where the sample size is increased from hundreds to maybe thousands. And in this instance, we continue to look at safety as the primary outcome measure, but then we also look at a co-primary outcome measure of immunogenicity. And really that immune response is a proxy for helping us to understand whether or not these vaccines can be predictably protective. So again, we may not know exactly what the best correlates for immunity are that to measure. In this instance, we're using neutralizing antibodies, but in many other instances for other pathogens, we in fact don't know what the best correlate of immunity is to measure. But anyways, that's just to describe that we measure the immune response in many different ways, and we continue to look at safety in an expanded sample size. Then we get to the phase 3, and that's where, again, we switch over from immunogenicity to efficacy as the outcome of interest. And this is finally where you actually demonstrate the whether or not these vaccine candidates may protect against the disease of interest. And so here, it's usually tens of thousands of people in a phase 3 study. And so what's quite remarkable is that we were able to march through each of these studies so quickly within a short time span. And part of it is because we were able to design these studies such that while we are still finishing out one of the studies, we would have a milestone, an objective milestone as a trigger to be started for the next phase of the study. So say after 56 days into the phase 1, and we've looked at all of the primary safety outcome measures and everything looks good there, then we start the phase 2 study, even though we're still continuing to follow up with the phase 1 candidates. And we continue to collect all the safety information cumulatively over time. So again, we're able to, in an accordion fashion, put these studies together. Still in a way in which we are not skipping over any of the safety procedures or the measurement of efficacy or sacrificing any other element in the conduct of these studies, but we're doing these studies in a much faster fashion. So what's really been helpful is that the US FDA provided guidance early on to really make it very clear and transparent to the manufacturers what are the guideposts for a vaccine to be licensable. So in other words, they're trying to make sure that manufacturers understood exactly how the vaccines should perform in order to be successful, in order to gain potential US FDA EUA approval. So part of that included the populations of interest. They needed to, in the course of those 3 studies, have a generalizable population that it's been evaluated in, including the high-risk parts of the population that we know suffer the most, the severest burden of disease. The efficacy that is designed in these studies need to be built so that they measured the prevention of symptomatic lab-confirmed infection. And if possible, it also said to measure more severe forms of COVID illness, which included, respiratory or kidney failure, hospitalizations, deaths, those sorts of things as well. And statistically, it had to prove that it had a minimum efficacy of 50% with a lower bound of the confidence intervals I think of 30%, if I wasn't mistaken. I haven't read the guidance document for a few months now, but again, it was made very clear by the FDA, which was again very helpful for scientists in designing these studies. So at the end of the day, when we designed these studies, we meaning the scientific community, what can we say about these vaccines, and what can we not say? Because I've seen in the chat, questions about what can we say about the safety, how long-term safety, this and that, whatever. Well, in the context of the studies that I've just described to you, with the objective outcomes that we're measuring in these studies, we can report out the common adverse effects, injection site reactions, systemic reactions that we can observe. We can also be able to describe some of the less common or more rare adverse effects. And these have to be really on the order of where there might be 1 or 2 cases per 10,000 individuals. But once you start to get to extremely rare adverse effects, again, these studies are only designed to test many tens of thousands. And again, the Pfizer vaccine was tested in 44,000 people before EUA approval. And the Moderna vaccine that's coming up before the VRBPAC this Thursday was evaluated in about 30,000 people. So again, that gives you the order of magnitude. So are we going to be able to know anything about the possibility of extremely rare adverse effects? No. We have not had enough individuals exposed to these vaccines to be able to understand if there are any of these extremely rare adverse effects. But again, if there is an adverse effect that is found in 1 in a million, would any of those adverse effects ever present a risk such that when you balance it against the clear benefit of a vaccine, and some of these vaccines that we're seeing are 95% efficacy, when you balance those two together, the risk-benefit ratio, I think that most people would agree that the benefit clearly outweighs that small, rare risk. Okay, so again, just to be clear, we do not know about extremely rare adverse events, but we continue to measure them even after they gain FDA EUA approval. Now, for the efficacy, again, I told you that these studies are designed to measure efficacy based on the prevention of symptomatic illness. Now, symptomatic illness is simply an illness that could just require a person to remain home and to recover and go on. So it does not tell us about the more severe it doesn't tell you about protection against more severe forms of illness, which again, as a physician, I certainly want to know that this vaccine is preventing death due to COVID, or even hospitalizations, or complications such as MI, stroke, or some of these other things that we've seen as risks due to COVID infection. Also, a lot of these studies are not able to tell us information about the effect on asymptomatic infections. However, there is some insight in these studies with the very small sample sizes, and I might be able to comment on that in the next slides. We don't know about transmission reduction because we don't know about sterilizing immunity. If we were able to, over time, do NP swabs or anterior nares swabs and do viral counts, basically, to look at viremia, then we might be able to get better at that answer. We don't know about the duration of protection. We don't know how long-lasting the protection is at this point, and we will continue to look at this. And right now, we have sample sizes that are rather generous, and we don't believe that we're detecting any differences in efficacy among subpopulations. And I've been very gratified to see that we still maintain high efficacy even among older adults, which is the bugaboo for me as an adult infectious disease physician, is a lot of our vaccines perform worse in older age. So here's the Pfizer vaccine, where again, I'm just summarizing to you that 95% vaccine efficacy when you count all participants. But then when you stratify by younger adults versus older adults, and this is the Pfizer definition of older adults, I in no way imply or endorse that a 56-year-old is an older adult. I don't want to be blamed for that as well. I think, again, what we are interested in, or I am as a physician, is an older adult that's 75 years of age or higher, because they really do have a logarithmically higher risk of hospitalization and death with COVID. So here's for the Pfizer vaccine study. When they designed the study definition, of course, was a positive SARS nucleic acid test within 4 days of a symptomatic period. And here are the symptoms that you can have in order to be counted as a case. Again, if you just had a sore throat, maybe a little bit of a cough, and you had a positive test, which is pretty mild symptoms, you're counted as a case. And so again, to have a vaccine that only prevents very mild COVID may not be very valuable. I would argue that if you had severe COVID infection and we showed high efficacy, that's where the real public health value is, if we're not able to achieve sterilizing immunity, which means that we don't have transmission blocking from person to person with vaccination. So anyways, severe COVID was actually defined in this study as severe systemic illness, respiratory failure, evidence of shock, significant of organ failure, admission to an ICU, or death. And so that is very helpful for us to also be able to look. These are secondary outcome measures for efficacy. And those have been published as well. Here, this is just showing you what I thought was rather remarkable, is that we have evidence of efficacy even after a single dose of the vaccine. So I think in the chat, I saw, what is the evidence? What happens if you only get one dose and you don't get the second dose? So again, I don't imply that people should approach this, but there is evidence that even a single dose of the vaccine can provide efficacy. Now, this might indeed be very short-term efficacy, and it might not be long-lasting. So I would still recommend that a person receive and complete the 2-dose series in order to confer longer-term protection. Again, we don't know ultimately how long that protection might be. Okay, and then here is the slide that shows you protection against that definition of severe disease. Now, in the context of this study, there were only 10 severe COVID cases. But among those 10, one of them was a vaccinee and 9 of them were placebos. So, when you calculate that out, it's wide confidence intervals, but at least this point estimate is rather hopeful. It's approximately 89% vaccine efficacy. So again, the confidence intervals are anywhere between 20 and nearly 100%. But again, that gives us some hope that these vaccines are really highly efficacious against severe infection, and even one dose confers some protection as well. So what can we say about the safety? Well, again, we've only followed these individuals since they've been enrolled, and enrollment started in late July. So really, we're only a few months into it. So, but we can know that that there are mild or moderate injection site reactions and systemic reactions. We know that they've been described as very much self-limited. In fact, we've had study participants that tell us, they come on within about 12 to 18 hours after vaccination, and then they seem to really disappear very quickly within about 36 hours, and certainly within about 48 hours. So, I just generalize that usually these symptoms, if they occur, last for about 1 to 2 days. They are more frequent after the second dose rather than after the first dose being administered. And so you can see the statistics there, at least for the descriptive statistics for what people experienced. No severe adverse events with vaccination were observed so far. And again, what I want to say is, there is a commitment for all of these manufacturers, even after they've gained EUA approval, that they will continue surveillance, safety surveillance, and provide that information to the FDA and CDC. And this is, again, to provide longer term safety information. All right, so here's the Moderna vaccine. I'm just providing you what's publicly available. We have had just yesterday, and I haven't had a chance to update this slide yet, with the briefing document that was submitted to the FDA, which provides the final analysis. And the final analysis is that 94% efficacy. This should be final analysis here. No safety concerns were observed. This study has enrolled, or about 30,000 people have experienced the vaccine or placebo. I should take away this bottom bullet. I didn't get to work on this slide yesterday. There's the AstraZeneca vaccine candidate, which again, we had a press release on November 23rd. And here they reported their interim analysis, which was based on the studies that are being conducted in the UK and Brazil. There are also concomitant studies that are being performed here in the US and Europe as well. Those data are not available yet. But at least at the time of this interim analysis, they reported on 131 evaluable cases. Now there was oops, I made a mistake in this study. I don't know if you were aware of this, but there are about 2,700 people that received the wrong initial dose of vaccine. In fact, they received half the recommended or the protocol required dose rather than the full dose. So in this analysis, oddly, you have about 2,700 people that received half dose, and then for their second dose, they received the normal full dose. And then the rest of the volunteers, about 8,900 received the full dose followed by the full dose, which is what the protocol stipulated. Now, when they looked at the interim analysis, oddly, you saw that the vaccine efficacy was about 90%. That was the point estimate for the people who received the half dose. And the point estimate was 62% for those that received 2 of the full doses. So it's a little bit counterintuitive. The hypothesis is that the half dose results in less of the nonspecific inflammation that actually might be detrimental to eliciting a proper immune response. And that's why that half dose actually resulted in better protective efficacy. Although again, this is just an interim analysis, and we really do await that final analysis. And I also would like to see what the US data and other data, again, cumulatively will demonstrate, so that we can really get a better idea of the overall vaccine efficacy of this vaccine. So again, this is a story that has not ended yet. And I think that, again, even if this vaccine only demonstrates 62% efficacy or 70% efficacy, it's still a valuable public health tool. All right, so I think I'll stop there. This is going back to that slide again to remind you that there are multiple other vaccine candidates that are coming down the pike. Some are close to the finish line. Some others haven't even started human clinical testing. I think, again, that the more horses we have in the race that come across the finish line, the better. We already are hearing about the Pfizer vaccine having very limited supplies, and even our limited supplies have been crippled because of logistical problems and other supply chain problems with some of their reagents. I'll also mention here that there was the Sanofi Pasteur vaccine that was under development, and we heard just recently that the Sanofi vaccine had a problem with poor immunogenicity in older adults in their phase 1/2 study. And so they're basically going back to the drawing board to see if they can make that vaccine better. Because again, they're predicting that it would not achieve the full efficacy that they desire. There's another vaccine being developed that was being developed by CSL Limited, which is a large influenza vaccine manufacturer in Australia. They were teaming with the University of Queensland. And that vaccine was under preclinical testing. And this week we also, or I should say last week, we heard as well about this vaccine candidate is actually being stopped because they had a safety issue. in the preclinical testing, immunized animals, when they looked at the antibodies elicited, they actually cross-reacted with HIV test antibodies. And so again, you don't want to immunize a large human population and result in false positive HIV testing. It's not that it caused HIV, but it basically elicited antibodies that cross-reacted with an HIV test such that a person looked like they had a false positive test. All right, so I'll just say a few words about vaccine policy and implementation, which is a large part of, once we have these viable vaccines, the national discussion of how to allocate these limited supplies. So we're trying to prioritize them. You're seeing that the discussion has been among trying to allocate them to the highest risk populations at first. We're trying to maximize utility, but you also see a lot of the discussion is trying to develop an equitable framework. How do we build in health equity, and how do we do this in an ethical way? So a lot of the discussion is driven by our decision making based on these principles as well. These national guidelines are being developed, but they're also made so that there's flexibility for the local jurisdictions to be able to use them. There's a lot of logistical problems with some of these vaccines, like the Pfizer vaccine requiring ultra cold storage conditions. And of course, I think even if we have these vaccines available, there's a big problem with public perception. And so we have a lot of work to do with trying to message out the real public health value of these vaccines and to try to fight against this growing wave of vaccine hesitancy, questions about safety, questions about efficacy, questions about Operation Warp Speed, skipping over procedures, those sorts of things. So a lot of this is on the discussion where I just say, we have to continue to message out the real public health value of these vaccines. These are just the population risk groups that we've been talking about internally in the ACIP work groups, and you've seen at least the phase 1A published just this past week. And these are the Venn diagrams, of course, because some people can be older adults with high-risk populations and a healthcare worker, which I say is like in the death circle right there of the Venn diagrams where you have all of the high-risk conditions simultaneously. And then the vaccine implementation, of course, when we have limited supplies, we'll have to target the vaccines to prioritized populations, but eventually we'll get to a phase where we have plenty of vaccine available. And that's where the strategy is, where you have to continue to surge in capacity to be able to deliver these vaccines. We have to use innovative and broad-based delivery approaches, which means local pharmacies, individual pharmacies, home health aides, visits, those sorts of things, to be able to distribute these to rural areas, also urban areas, really making access not an obstacle or a hurdle for any of the populations. And then in a final phase, we're going to continue to have to push because there's continued vaccine hesitancy in the population, and we still have to continue to increase access and increase messaging and awareness, and again, offer the public health value such that we can achieve, that greater than 70% community-wide immunity, otherwise known as herd immunity. So meanwhile, we're going to go, while we're delivering these vaccines and trying to implement them, we need to continue to adhere to the old-fashioned mitigation and control measures to limit transmission. And so we've already talked about in the prior two talks as well. So thank you very much. This is a picture here from about 2 months ago in the Netherlands, where they had a subway car that actually went out of control and went past the station it was supposed to, and would have dropped dramatically, but it was saved by a whale's tail. This is a sculpture that actually serendipitously was in the right place at the right time and held up the out of control car. So I oftentimes feel like this during this COVID situation is that, these vaccines are being developed at remarkable speed. And, if we can get out of this, I'll feel like we're being saved by a whale's tail. So thank you very much, everyone.
Thank you, Dr. Chen. I think because of the limited time, what I will do is some of the questions you have already answered. So we'll go over with some of the specific questions that need to be addressed. So one question I really like, I think that's for Dr. Kashmira Dey, that they have asked a question, does different microbiome plays a role in COVID cases in Asia and Africa? That's Dr. Murthy. That's pretty legitimate question about the microbiome and the COVID cases. Dr. Dave?
Actually, I'm going to defer to my colleague, Dr. Todd, to answer that question.
Dr. Davis?
So just to clarify, is that the microbiome within the individual or the microorganism itself? We clarify?
I think it's more individual as far as I know.
Yeah, so certainly there would be some, underlying factors that might lead to more severe infection, but I do not know if there are specific studies addressing the individual's microbiome and related to clinical severity.
Right. So this is a question for Dr. Chen and Dr. Davis both, because this comes around all the time, and we are dealing the same with our residents and healthcare providers. Patients with mildly symptomatic patients who have positive test after the recommended 2 weeks quarantine, when they are released to work, do their tests become negative? Can the asymptomatic patients after the quarantine still have positive tests, and can they be released to work and community? It's a very good question, and it's always a question in mind whether they are asymptomatic carrier, are they going to spread? And this time frame of 2 weeks is more based on the postulate and hypothesis and the work done. So I will defer it to Dr. Chen and Dr. Davis, whoever wants to take this question.
Well, I think that the guidance has changed a little bit over time, and part of it is because we've been learning so much about this virus. I think that we were very much surprised at the fact that this virus can cause asymptomatic illness at such high rates and be highly transmissible, which again, we don't see that for like influenza and others. So that's I think been a factor in the decision for the quarantine period. What I'll also say is, as I understood, and I haven't looked at the guidance more recently, but what I understood was that we're not instructed to repeat PCR testing on individuals once they're positive, and whether they're symptomatic or asymptomatic. And that's because these PCR tests can pick up dead virus, doesn't mean it's live. So I think that quarantine period should be strictly adhered to according to the FDA guidance. So I guess I would have to refresh my mind, honestly, to go back and look at the FDA guidance for that. But I don't believe that there is any guidance for repeat testing for a person who has already been lab confirmed. And once they've undergone their period of quarantine, that they should be fine. Dr. Davis, you probably can correct me.
No, I agree 100%. I think there's no recommendation from CDC for repeat testing. And there, as you mentioned, has been some changes in the number of days that the CDC recommends post. So if you have a negative test, they now recommend only a 7-day quarantine from that negative test.
Negative test, yes.
10-day quarantine, positive test.
Okay. Thank you. This is another very good question, actually. What is the recommendation for giving the vaccine to immunocompromised people, like patients who are diagnosed with cancer, chemotherapy? And this question is very close to me too, because I'm a transplant nephrologist. So we are getting a lot of questions. And what are your recommendations, both for the chemotherapy, immunocompromised, even the patients with rheumatological disorders? What do you suggest? It's an mRNA vaccine, so there is some questions and concerns.
Right. Well, so my concern would be for any of the live virus vaccines, that we typically do not use live virus vaccines or any live vaccines in the immunocompromised. So these mRNA-based vaccines are not contraindicated for the immunocompromised. In fact, they are being recommended because we recognize the immunocompromised are at the highest risk of severe disease with a COVID infection. The other end of the spectrum is that we predictably think that vaccines may not be as immunogenic. So we may not elicit the full efficacy of a vaccine compared to a normal human host. But again, The value of these vaccines is that we're trying to get the population immunized as well. So for the individual, you may not have the 95% efficacy in the end. You may have just 70% or something else. But again, I think that that's still valuable. So I think that that's the approach. So for your patients, I would recommend that they do get vaccinated.
Here's another very good question, like how long antibody level lasts in a positive test and there is any chances of reinfection?
Yeah, so there is some very recent data showing that there have been detectable antibodies for up to and greater than 200 days post-infection. And so as they have followed individuals from the early stages of the pandemic, we do know that antibodies are persisting for many, many months. And so I think that's good news. I think the challenge is understanding whether those antibodies are neutralizing antibodies and if they will protect the individual. And I don't think we're thinking really in terms of sterilizing immunity, but just in that partial immune protection that would prevent at least replication of the virus. There could be some replication, but not to any extent that would allow for severe disease or even symptomatic disease. But I think a lot of it's going to be based on whether or not we have good neutralizing antibodies in the assays to be able to discriminate between IgG, IgM, and those neutralizing antibodies.
There's another question. Should we worry about unknown long-term side effect of the vaccine? Historically, do vaccines have delayed side effect? And if it is, what they are? Dr. Chen?
So there are very few long-term side effects that have been identified as linked to vaccinations. I think that again, for the vaccine hesitant community, they always bring up the specter of autism and some of these other things. And there have been hundreds and hundreds of studies that have been performed that have found no association at all. So really, I think that we need to move beyond that. There really has not been these long-term associations. The only long-term association that really comes to mind for me as one that potentially is implicable to a vaccine is rotavirus vaccine and this intussusception it's a pediatric vaccine. It killed one of the early rotavirus vaccines and newer rotavirus vaccines were developed. And again, this was because of intestinal kind of intussusception, which would occur within the months after vaccination. So in this instance, again, there's the theoretic possibility that there could be long-term side effects, but we, again, have a commitment from these companies to continue to do post-marketing surveillance to report that information to the FDA and CDC, and these will be, transparently communicated to the public if there's any sort of association that is found with these vaccines.
What about the reported cases of the Bell's palsy? Is it any concern?
Yeah, so Bell's palsy, the larger context is that we see Bell's palsy about 15 to 30 cases per 10,000 people. That's in the general population. 15 to 30 per 100,000 people in the general population. And that's really the background rate. So in the Pfizer study, there were 4 cases of Bell's palsy that were observed. 30,000 people, 4 cases in 30,000. So that's still around the frequency that you would see in the general population. In the Moderna vaccine, we also saw 3 cases of Bell's palsy among vaccinees. Again, it's around what we see as a frequency in the general population. We'll continue to follow it. Thank goodness Bell's palsy is not a permanent condition. It's largely something that is temporary and you usually resolves by itself within a few weeks. So again, the public health value of these vaccines, are you going to weigh the possibility of Bell's palsy, which right now does not occur with a higher frequency above what we see as a general rate among the population, against the true proven benefit of the vaccine, which is against symptomatic illness, but even hospitalizations as well. So again, that's what I want people to understand is we'll continue to watch this, but in the end, will it upend the public health value of the vaccines?
I'll summarize. There's a lot of questions coming in, but I can summarize 4 or 5 questions into 3 parts. Number 1, efficacy in the pregnant woman. Second, which is also very close to me, is like, is it efficacious or any studies done in pediatric population? Third, any issues of infertility for these vaccines?
Yeah. So the formal studies have not been done among pregnant women and women who are breastfeeding. So the answer is that we don't have official data or formal data for those. In the studies that have been performed, there have been about 30 women that became pregnant during the course of the study. So we have those data. But again, there's no kind of mechanistic hypothesis for these vaccines interfering with a pregnancy, posing a risk to the pregnancy. We know that some pregnant women can be highly susceptible to these infections. So we again recognize them as a population that we want to get vaccinated. So again, the CDC, the ACIP recommendations for the Pfizer vaccine is that it's not a contraindication at all. And in fact, we would want to have a discussion and to still allow the pregnant woman to decide, but vaccination can be done. And I would say I would still recommend vaccination after that discussion. Now, as for children, the pediatric trials are just underway. And so I think for the, is it the Moderna or the Pfizer? I'm forgetting now. The adolescent studies just got started this past week.
That's
so again,
Moderna.
The Moderna.
That's Moderna.
Yeah. So again, those data are underway right now. Thank goodness, in general, the pediatric population is a lower risk population. Not saying no risk, because we have seen very severe illness and the MIS-C complication with COVID. But again, they're rare, and in the whole scheme of things, we know that older adults, people with underlying comorbidities, and others represent that high-risk population for which we have prioritized for vaccination. So again, we're doing these studies right now. We will collect these data, and that will inform our vaccine policy decisions.
With the time, I will just leave this as a last question, because a lot of people are asking. Some of the questions were about having a probiotic use and all, and putting the data there. But I think this question will come up. The patients who already have COVID-19, they recovered, should they get the vaccine? Because that's pretty legitimate questions. Or those people who have positive antibodies, as you are saying to the children, we are seeing a lot of spectrum of Kawasaki overriding and not including the cardiac manifestations with just missed presentation. So my question is, those patients should get vaccine or should not get the vaccine? Those who have positive test, recovered, doing well.
Yeah. At this time, the ACIP recommendation is that those individuals that have had a recent infection with COVID, that they wait for about 90 days and then get vaccinated. And this is because largely people who have natural infection with COVID, especially the milder symptomatic cases, the antibodies are shorter lasting. Now, some of them can be longer lasting, like Dr. Davis said, but I think a lot of them can be shorter lasting. So I think we just basically said, wait for 90 days and then get vaccinated. And what that allows us to do is to prioritize people who clearly have not been exposed, who might not have, again, that partial immunity conferred by natural infection, to go first. And so those 90 days buys some time for those individuals with the highest risk to be able to be vaccinated before the individuals that have already experienced a natural infection and might have that natural immunity.
It's amazing. There was a lot of questions coming in, and thank you for all the enthusiastic questions. Some of them are very pertinent, but because of the time commitment, I will now give the podium to our API president, Dr. Sudhakar Janalwala. He will conclude, but on my behalf, I want to really thank Dr. Kashmira Day, Dr. Todd Davis, and Dr. Chen. And as I said, when I was doing a study in H1N1, when I was a fellow, I read a lot of paper of Dr. Davis, and it is nice to see him virtually. And it is really a very, very nice and learning session, I should say, and perfect timing with a lot of concerns and a lot of misconceptions going on. As a physician, we are unable to answer these questions, but this was very, very nice kind of discussion to flow from epidemiology to the vaccine and then the implication of that. I really want to thank the API president and the API committee for giving me a chance to moderate this session. I will now give podium to our president, API president, Dr. Sudhakar Janalga.
Thank you, Rupesh. Thank you very much. What a educational seminar today. And first of all, I want to thank you, Rupesh Raina, for moderating section, and thank you for your time, Rupesh. And the speakers from CDC, Dr. Date and Dr. Todd Davis, thank you very much. Thank you. You know, I'm taking almost 4 or 5 months now hunting for these speakers, you know, to get him today. Thank you for joining, Dr. Chen. What a excellent discussion today. You know, we really update us everything. Our members are so delighted. I'm sure, you know, they appreciate all your time today. Thank you very much. One last question, okay, for Dr. Date. There is a question from the audience that, you know, if you take a long distance flight, for example, 4 to 6 hour flight, what is the risk of COVID infection?
There, you know, there have been quite a few studies that have looked at, you know, how in terms of the risk when you're traveling at airports and within flights and things like that. I think a lot of information out there. We have seen that it depends on, you know, if there has been a symptomatic case around, you know, where some of the passengers are seated. And so some of that, I think, you know, again, the data is a little bit, it depends on, you know, whether there was a symptomatic case or not. I think, you know, again, what we've seen in terms of the transmission within air, you know, like within the airline, within the airplane, in terms of the air circulation and all of that, I think that doesn't pose a risk as such. But it depends on whether there is a symptomatic case around where you are sitting. So that's why I think it's really important that if there is if people have symptoms, to really avoid travel, and, you know, to use all of those mitigation measures that we have been promoting so much. You know, wear a mask at all times, try to sanitize and clean around where you are. So that's something to be, you know, really, I mean, and really not avoid any non-essential travel.
Thank you very much. Thank you, Dr. Date and Dr. Todd Davis and Dr. Chen and Dr. Rupesh Raina. Thank you very much and stay safe. Good night.
Thank you. Thanks a lot. Bye-bye.
Thank you. Bye-bye.